Today we are going to discuss the role of lung ultrasonography in COVID pandemic. And the chair for today will be Dr. Daniele Guerino Biasucci from Fondazione Policlinico Universitario Agostino Gemelli, IRCCS. And he is a consultant intensivist, and he currently works at the Neuro ICU in the Policlinico Gemelli here in Rome. He has a specific interest and education in ultrasound in emergency and critical care, vascular access, neurocritical care, antimicrobial stewardship. He teaches in various master degrees at the Catholic University of Sacred Heart. So it's a real pleasure to have him here today. The meeting rules, just as always we do, the meeting will be recorded and will be published on the project website. You can ask questions anytime using the chat, but then the questions will be addressed during the Q&A session. Please keep your mic and camera off unless you're asking differently, because this will help those who have not a good connection. We will take some pictures during the conference. If you do not wish to appear, please leave your camera off. So just to give you a brief overview of the No Fear project, this is a pan-European network of practitioners, decision and policy makers and suppliers, and also university as academia in the field of emergency medicine. Clearly, during this COVID pandemic, we really were interested in this, how we work and how we can go through this really tough time. And so the objective is to overcome the fragmentation and improve the response of the emergency medical system to new threats. Here the project website, but you will find all the relevant information at the end of this session. So please, Dr. Biasucci, the floor is yours.
Good afternoon. Thank you very much. Thank you very much to the network for this invitation, and welcome to everyone. Very much for connected here.
Dr. Biasucci, may I ask you to speak a bit louder?
Okay, can you hear me now?
Thanks.
Okay. Thank you again for to the network for this invitation, and welcome to everyone for being connected here with us. So I'm very happy to chair a session about lung ultrasound. I'm very passionate about ultrasound in emergency and critical care, and this is a very useful tool in many settings. We well know that this tool is used in emergency setting, and also in disaster emergencies to detect traumatic injuries of the lungs. And during a pandemic, lung ultrasound may have a powerful tool, not only to make diagnosis of an interstitial pneumonia in case of COVID-19 suspicion, but lung ultrasound allows to monitor the severity of the disease, and being a bedside non-ionizing tool, it can be used on the scene by the emergency physicians. It can be used in the emergency department also in case of a massive surge, and it can be used to monitor disease progression both in COVID-19 dedicated ward or COVID-19 dedicated intensive care units. So it's a very powerful tool in case of a pandemic. So we are going to talk about the experiences and both on the scene for lung ultrasound provided by the emergency medical services, and both in the emergency department, and we will talk about also about the experiences and the use of lung ultrasound in COVID-19 related ARDS. So we have 4 excellent speakers, and I suggest to go ahead, and it is my pleasure to introduce the first speaker from Spain, from Madrid, Ervigio Corral Torres, on emergency physicians who is going to talk about the use of lung ultrasound on board and during emergency on the scene. Please, Ervigio.
Ervigio, can you hear us?
Okay.
Yep.
Yes, now, no? The slides pass for you? Do you pass the slide?
Yes.
Yes, okay. Good afternoon. First of all, I would like to thank the organization of this webinar for allowing us to share this experience with you. No? But next, please. But as I wanted to make clear in the title, this diagnostic technique is performed in the context of a service that already has significant experience in the use of ultrasound for other pathologies, for other processes. Thus, ultrasound was implemented in our service in 2007, and since then, all advanced life support units have this device on board. And responding to some of the items of this webinar, very few in my country, very few emergency service use this technique on a regular basis. After so many years of being established in SAMUR, only one EMS helicopter service has them as a regular resource. No? Next, please. The incorporation to my service was carried out after a course given by radiologists from Madrid hospital. But obviously the incorporation was progressive, no? So that in the first years it was limited to the simple, no? In the following years, progress was made toward the expanded echofast, and then with better device to the echocardiography. No? And this year, in this month, we are training doctor in lung ultrasound related mainly to the COVID. Next, please. Next. The nursing staff has also been trained in this technique in relation to ultrasound of the venous line, of course, now using a linear transducer. No? For years now, and given that SAMUR has a training agreement with most of the university of our city, both medical students and postgraduate and master degrees are trained by our doctor in basic ultrasound. Please, next. In the same way now as the training, the incorporation into the procedure of the service was gradual. In the early years, its application was exclusively for trauma. Afterward, one of the most important utilities for us is the cardiac arrest. But to detect some of the disease, no, especially in traumatic cardiac arrest, and to detect the presence of pulse. Thus, we have realized that most situation of pulseless electrical activity are not true. Of course, the treatment is very different because the patient has in that moment pulse, but it's not detectable for the normal methods. Years later, it was proceeded in pulmonary thromboembolies, where ultrasound is the main technique in the diagnosis. Please, next. In terms of the device, this is the evolution that we have had in the service. This is the most basic, in which it was difficult to see anything that free liquid in the abdomen or pericardium, no? perhaps this has been the device most adapted to the emergency. It's very hard, it's ruggedized, no? And we have in the last step a few number of this high quality device for the person in charge, for the doctor person in charge on duty in the service. Next, please. Referring to the use of ultrasound in the lung interstitial lesion, as is the case of the COVID, there are many articles. Sure, you have more articles and more interesting, such as this, no? In which its high sensitivity has been proven. This, together with the logistical facilities provided by this device, make them very useful elements in the management of this patient, especially in areas where the conventional radiography or the scan is not easy, no? And where there is a significant volume of patients. Next, please. Another objective of the webinar was to know the ultrasound protocol adopted, no? I believe that the most common and simple is this protocol called Blue, sure you know. With its name express, the lung ultrasound in emergency can be developed at the scene of the emergency. It's simple and is based on 4 ultrasound patterns, mainly based on the appearance of a number of P lines. Next, please. In a more visual way, this would be the ultrasound images corresponding to these 4 patterns. As we can see, in the pattern A, we can see the lines A, those horizontal lines with our images of normality. In patient B1 and B2, this B line appear, which are pathological if their number is greater than 2 in its space. No? Also, the absence of pleural sliding is a pathological sign, of course. Next, please. As for the use we have given at this time, it has not been a homogeneous use, no? Because the pandemic surprised us, no? And we had not possibility to train doctors in a practical way in the first moment of the pandemic, no? Some of us began to use in this patient, surprising us its simplicity and applicability. As we will see later, one of the main use was in the nursing homes, but it's certainly a good triage method. I remember that some of us used this device in the triages, in the triage we did in the IFEMA hospital. IFEMA hospital is the great hospital created in Madrid in the first wave of the pandemic, to differentiate the most serious COVID case from those that were in a moderate phase. Next, please. On the 12 windows that are described in an interstitial lung evaluation, we usually start by using 2 windows, one anterior and one axillary, so that we can evaluate a good number of patients without causing greater discomfort to them. If in any of these 2 windows we notice any irregularity, we would continue with the posterior and inferior ultrasound examination. Next, please. As I have mentioned before, the place where we have used it in the most case has been in the nursing home, no? An area where the hospitalization decision is very important and multifactorial, no? The patient dependence status, previous pathologies, cognitive status, and the approval, of course, of family members, no? A good number of patients have been explored in a few hours in order to make this type of decision. And that's all at your disposition for any question. Thank you very much.
Thank you very much, Ervigio. So we will leave questions at the end of the session. So we can go ahead with the next speaker, and I introduce Cristina Sorlini from an emergency physician from Milan, and she's going to talk about lung ultrasound and COVID-19 pneumonia. I think we will talk about specific signs and especially about the experience on the use of ultrasound in COVID-19 massive surge in the emergency department in Milan. Please, Cristina, thank you.
Yes, good afternoon. So the aim of this talk is to give you some ideas on the findings when we scan the lungs of patients affected by COVID-19 pneumonia, and I will present some data from one of our studies we conducted during the first wave of the pandemic. So if you can go to the next slide, please. So actually, the role of ultrasound to detect lung pathology has been explored widely. And what we learn is that actually what we see during lung ultrasound, and when we see something abnormal, something pathological, it arises when the disease reaches the pleural line, because the ultrasound obviously is able to detect the difference in the air fluid content of the lung. So a normal lung is full of air, so we just see artifacts. And when we have a lung which is full of exudate or fluid, actually, we can see something more than usual. And if we can go to the next slide, please. So the first thing we want to say is that when we scan a lung, usually we use a probe in a longitudinal way. And on the next slide, we can appreciate a normal lung. So basically, what we can see is the skin and the soft tissues and the muscle, and the little curves with the black shadowing underneath. These are the ribs, and in between we can see the highly hyperechoic pleural line. And on the next slide,
Cristina, I just tried to give you the remote control, so you can also indicate somehow if you wish. Yeah.
It's so actually we can see these lines which correspond to the ribs, and underneath the black shadowing, and after that in between we can see this hyperechoic line, which is the pleura. Okay, so on the next slide, okay, fantastic. So this is called the bat sign, and we can identify the pleural line in between two ribs. What we see on normal, so the air-filled lung, is that when we scan the lung, the first thing that the beam hits is the pleural line, and then the beam itself bounces back and forth. So we see a set of different horizontal hyperechoic line at the same distance from the first pleural line. These are artifacts which are called A lines and correspond to normal lung. What we see is a sort of so-called mirror effect. Okay, the beam bounces back and forth, but actually not traveling through the air-filled lung. When we have a pathological fluid-filled lung, what we see is that the pleural line is disrupted, and we start to see the actually ability of the beam to travel through the lung, through the fluid, which is within the lung, and this becomes more and more dense when the fluid content increases. Okay, and is this the same concept? So when the pleural line is not disrupted, we just see A lines. When the consolidation or fluid reaches the pleural, the beam goes through the lung, and we start to see these beam-like features, which are the B lines. And we define the interstitial lung syndrome when we have more than 3 vertical B lines within a single area of the lungs, and the interstitial syndromes must be bilateral, so at least 2 different areas of the lungs on both sides. And again, on the left, a normal lung with just horizontal A lines, and on the right, sorry, the reverberation, which gives rise to the B lines, which are vertical. And again, it depends on the amount of fluid and the amount of disruption we have on the pleural line. The B lines can be very sparse or coalescent until we have something which is called the white lung, so completely disrupting the normal conformation of the lung. Again, this must be a video. Okay, you see the pleural line sliding, and then we see the B lines moving along. And this is an image of the white lung. So in COVID-19 pneumonia, we used to scan the patient in 6 different areas of the lung, according to the blue protocol, which was actually firstly described by Liechtenstein. So we can actually have a sort of scoring of the involvement of the lungs. The posterior areas are usually more affected, but when a patient has the anterior aspect of the lungs, which is involved, this means that the pathological process is very widespread. The usefulness of the lung ultrasound in COVID-19 pneumonia is that actually is very, very sensitive, more than X-ray, and it has a sensitivity which is similar to CT scan. The downside is that it has a very low specificity because, I mean, B lines are common also in pulmonary edema or fibrosis. So the tool can be used when we have a high prevalence of the disease, like during a pandemic. So 86% of the patients coming through the ED doors will have COVID. So we can use a ultrasound with a high positive predictive and negative predictive value because of the prevalence of the disease. And again, this is what we usually see. So the interstitial lung pattern. And we can differentiate these different pathologies because actually in COVID-19, we have the B line, the interstitial lung pattern, but usually we have a very disrupted pleural line with an irregular pleural line with some consolidations just underneath the line itself, which is not common for other pathologies. So actually, what we find is that ultrasound can detect pneumonia when the prevalence of the disease is very high. So people coming in with symptoms that are highly specific for COVID-19, but not specific for pneumonia, they can just have their lung scan, and we can detect even very initial small areas of consolidation. This is the image of one colleague of mine, which actually had COVID, and he came in mildly desaturated. And as you can see, the chest X-ray was completely normal, but his ultrasound was positive for B lines in the posterior right lobe. There is a correspondence between the CT findings, which are ground glass opacities or consolidations with patch involvement and without hydrostatic gradient, and lung ultrasound. So we see here disrupted pleural line with some subpleural consolidations and some B lines. What we found actually was that we have a very good positive and negative predicted value when we use lung ultrasound during a pandemic. We actually have, in a couple of months, we had 500 people diagnosed with COVID-19 in our department, and we had ultrasound results in 384 patients. And based on our results, the sensitivity of ultrasound was 92%, with a mildly low specificity, as I told you, which was almost 65%. But given the prevalence of the disease during the pandemic, the positive predictive and negative predictive values were high, 88.6% and 73.3%. The limitations of this study was that actually it's retrospective in nature, and obviously all our colleagues in ED had to be trained, and most of them were trained before the pandemic with a single-day course on lung ultrasound and at least 150 supervised examinations. One of the limitations was that we didn't have any standardization in our reports, so it was sometimes very difficult to understand the degree of involvement and the actual findings. So there were very different way to describe, from B lines on the lower lobe to a more specific description of the opacities and consolidations. And actually, one other limitation was that some of our patients, they were treated as non-COVID patient based on the on a single result of the nasopharyngeal swab, which actually was not the standard at that moment. So probably some false positive on ultrasound were indeed positive, false negative on the swab actually. And probably if we had repeated the swab twice, we would have a higher level of concordance. Just to conclude, actually, the use of lung ultrasound is primarily for diagnosis, but also to detect complication during ventilation, like pneumothorax or pulmonary embolism. And we know that the prevalence of embolic disease is quite high in COVID-19. And obviously we can always scan the heart to see the preload and the ventricular function, and obviously the hemodynamic changes on the right ventricle in case of pulmonary embolism. The other limitation of ultrasound is that if we have central lobe involvement and not peripheral disease, the ultrasound is falsely negative. So CT scan has a higher sensitivity because it can detect pneumonia anywhere in the lungs. to conclude, actually, lung ultrasound in COVID-19 is, we demonstrated that it is highly sensitive. It is helpful because it allows a sort of stratification. It allows the monitoring of the disease progression. It's cost effective and doesn't expose to ionizing radiation the patients, has low cost, and actually it reduces the cost and the numbers of CT scan we can request, which are a limiting factor during a pandemic. Let's see. Thank you so much.
Thank you very much, Cristina, for this very excellent presentation. We have some good points to discuss. We have two main messages, I think. First of all, there is some specific signs in COVID-19 pneumonia, and also we well know that lung ultrasound reaches its maximum effectiveness only when clinically integrated. And then we can also monitor, look at the heart or complications of the treatment of COVID-19, like pneumothorax due to ventilation and many other complications or different conditions for typical in these patients. So go ahead with the next speakers. We have the pleasure to listen to Michiel Dont, and we will hear about the experience on the use of lung ultrasound in COVID-19 patients in Belgium. Thank you, Michiel, please.
Good afternoon, everybody. I'm pleased that I can share our experiences from lung ultrasound during the COVID pandemic. So I'm going to tell you a bit more about our use of ultrasound in the emergency care department. First, I'm going to start with some of our facts and figures. So we encountered already 3 waves. The first wave was an European wave. Everybody encountered that. The second wave passed during the months of July and August. It was a smaller wave with a lot of patients in the area around Antwerp. And then now a third wave, which is more severe than the first and the second wave. And we didn't fully recover from the second wave when the third wave struck us. So since the start of the pandemic, we had 560 hospitalizations, 138 were admissions to the intensive care unit. We had a 10% positivity rate from all the PCR tests we performed at the emergency care department. And we had a 200% rise in ultrasound use, mainly caused by an increase in use for lung ultrasound. So in the emergency department, we performed 11,159 PCR tests, where 1,062 came positive. Why did we go to LUS? We had already a lot of experience with the use of ultrasound. We do EFAS protocols for trauma care, we do rush examinations and POCUS. We use ultrasound on a daily basis because we had an ultrasound machine that's easily available and easy to use. We have a Sonosite with us, which is foolproof in use. And with the Sonosite export, we have three types of probes with us, so we can perform every examination with the same machine. So when the pandemic started, the first month, we did a literature research to make a protocol for using lung ultrasound for COVID-19. There was not a lot of literature available on COVID-19 and lung ultrasound, but with the scarce literature we found, we made a protocol that was easy to use for the staff members and the trainees that were on our emergency department. As you can see on this slide, we made 3 columns. The first column is how to use the ultrasound machine and how to perform the examination. So as already told, we did a 6-area scan on both sides of the thorax. Very important, but a little bit small on the protocol was the hygiene. I will come back on that later. Then the middle column specifies the ultrasound findings. We made 4 rows with different colors to make it easy to decide which management you had to do when you saw something. We also put some pictures of the findings in the protocol so you can compare that with the live images you made on the ultrasound machine. As you can see, we have 4 different categories in our protocol. Is a normal ultrasound. If we had a patient, mostly of the time we sent him home if this was clinically okay. Then we have the mild findings, and then we decided if there was more investigation needed based on the clinical symptoms. The 3rd row is an orange row where you can see there was a lot of B lines. And mostly of the patients in the orange zone were admitted to the hospital, sometimes to the medium care unit for non-invasive respiratory support. And then the major findings were a white lung, were sent to the emergency care unit. Mostly of the patients with major findings didn't get an X-ray, but immediately go to CT to see if which was the problem in the lung, how many of the lung was damaged by the COVID-19 infection. This protocol is widely available in our emergency department. It's printed on a lot of big papers, so you can use it during your examination of the patient. Was there an impact of the use of LUS on our emergency department? Certainly. We were able to triage the patients. We could differentiate between the severity of the patient. We could manage our flow. So as you can see, the pandemic struck very fast in exponential growth. So we had to perform very well on our emergency care department, and the use of ultrasound made it easy to shift the patients to the hospital or send him home. Another good thing about learning emergency ultrasound at the emergency department was a steep learning curve. It followed almost the same course as the pandemic, so we were able to learn fast when the infection rates climbed. And we were able to train the trainees very early because we had a bit of experience with ultrasound, and after a few days, few weeks, we were maybe experts in using LUS, so we could teach the trainees to do it. So now most of our trainees and staff members are able to do the lung ultrasound for COVID patients, and it has a big impact on the performance and the flow and triage of COVID patients. We were also faced with a lot of problems and some problems with the use of ultrasound. So as all the emergency department had to make 2 units for non-COVID and COVID patients, we also had to separate the patients, but we only had 1 ultrasound machine, which was used for the non-COVID patients. So we had to have a second machine. So we took a machine of the operation from the anesthesiologist because they didn't need it because all the normal activity was suspended. The most important problem with the second ultra machine was data connection. So we had to set up a new data connection to catch the images and save the image to the electronic health record of the patient. It took some time to get it in order, but now finally it works well. Another problem was the infection control. So as you can see, our ultrasound machine has a lot of knobs and touchpads, so it's difficult to clean it because you can't clean all the area of the ultrasound machine. A second problem is the cleaning of the probe. We had a lot issues with finding the right cleaning method for the probes because it's not every disinfectant can be used for cleaning the probe. Validation, as already told in the previous slideshow, ultrasound for COVID is not able to visualize deep injuries. It's only good for superficial injuries and changes in on the pleura. And findings are not to always see the patient and correlate it with your clinics if you have some artifacts on your echo. So we have to see in the future how we can increase the specificity for lung ultrasound in COVID-19. And the biggest problem, I think, for us in COVID-19 is the observer-dependent investigation. So you can, ultrasound is a dynamic investigation. So every observer of every person that used the ultrasound will have different images. If you scan a patient like on a statistical way, you see what the probe is put on, but you can miss artifacts or you can miss injuries. In Belgium, we have a special vehicle which goes to patients. It's like called the MUG, it's a mobile urgency hub. In the vehicle, there is everything you can find on the emergency department, and we have also an ultrasound on board. It's a handheld small ultrasound. In the vehicle, we have a physician, we have a nurse, and we have an ultrasound. We have the same experience and knowledge that is in hospital and now pre-hospital, but there is one problem. There is a limited use of the ultrasound, but we don't know why. So we are looking for a solution why we didn't use the pre-hospital ultrasound as much as we do in hospital. Thank you for your attention. Are there any questions? But I think the question will be answered later.
Thank you very much. Thank you very much. Very excellent presentation. I think that there is one more great point to discuss. It is very important to develop an algorithm, a protocol like that you have adopted at your institution. So allowing the lung ultrasound as a role in optimal patients and resource allocation, and also for a proper indication and timing for further diagnostic imaging like CT scan. So it obviously has a great impact on the management, the flow management of patients in case of a massive surge of COVID-19 patients in an emergency department. So we will discuss about it soon at the end of the session. So now we can go ahead, and it is my pleasure to introduce Belaid Bouemad. Belaid is an intensivist and an expert in lung ultrasound. He has authored different papers on the use of lung ultrasound in ARDS, and now he is going to talk about the use of lung ultrasound for monitoring disease progression and so on in COVID-19 related ARDS. Thank you very much, Belaid. Please.
Can you hear me? It's okay?
Yes, yes, please.
I don't know why. Okay. Just few words to share with you. Our experience with lung ultrasound for monitoring COVID patient ARDS. Okay, we use as it's a protocol in our unit, but we use always for every patient the lung ultra score. It was it was described also by Cristina. We make an examination, a comprehensive examination of the patients. We look at 6 areas by hemithorax, anterior, lateral, and posteriors. And for each areas, we check for 1 and 2, 3 intercostal spaces. And we do that for the birth lungs, the right, and the left. And for each areas, we give a score according to the pattern of lung aeration found. If we have a normal aeration, we give 0 point. If we have a moderate loss of lung aeration with only few B-lines, we give 1 point. When we have a severe loss of lung aeration with coalescent B-lines, we give 2 points. And when we have a full consolidation, we give 3 points. So for 12 areas, we have a score ranging from 12 times 0 to 12 times 3, 36. Okay, and we have to make this lung ultrasound at admission and at every 2 days or every 3 days to the patient to monitor the lung status. During the first wave of pandemic, we admitted around 100 patients on 45 beds, from 40 ICU beds, 45 beds ICU, and we monitor, as I previously described, the lung ultrasound monitoring. Here you have some results from this patient. To say the truth, 6 patients died at their admission and were not included in this study, in this result, sorry. And we compared 2 groups of patients who stayed in ICU less than 15 days and patients who stayed more than 2 weeks. And patients who died were included in the patients who stayed more than 2 weeks. On the left panel, you have here the lung ultrasound score for the good patients and for the bad outcome patients. And as you can see, they came with a high lung ultrasound. We have only very severe patients, ventilated or patients needing high flow nasal oxygen. And as you can see, the median score of the lung ultrasound is very high, more than 20, around 20. And for example, here we have 2 severe patients with score greater than 30. That it means that the lungs is considered more than 80%. And as you can see, at admission, we cannot, from the loss, deduce which patient will stay only 15 days, and which patients will stay more than 2 weeks. And as you can see also, all the patients has a lung ultrasound score greater than 10. And this is the lung ultrasound score at day 7. For example, in this patient, some of the score were obtained at when they leave the unit, and they leave the unit with lung ultra score remaining elevated. So we look at the CT scans, and we try to understand why we cannot deduce from the lung ultrasound, for the monitoring of the lung ultrasound, what happens. For example, this is a patient or a 70-year-old woman at admissions, and as you know, as you can see also, there is a lot of ground glass opacities. You can see here consolidated ground glass opacities. When they are nodular or solid, we can see here consolidation and subpleural consolidation, and of course, pleural line irregularities with multiple belines everywhere. And sometimes we have some normal region. This is, on the contrary, the CT scan of a 65-year-old man after 25 days of mechanical ventilation. And you can see that the picture is quite different. There is no so much ground glass opacities, but we have here fibrosis with thickened interlobar septa. Those thickened interlobar septa are detected as large pleural irregularities, and even we can see here septas here, and less belines than the previous patients. So for us, maybe the decrease in lung ultrasound is a bad sign with the appearance of fibrosis. Maybe we have to confirm that. So this is our procedure now with COVID patients when they come in spontaneous breathing. When, for example, we go to the emergency department, if the lung ultrasound of a patient is less than 10, we not worry. And of course, we have to take into account the clinical context and the clinical signs. But when we have lesser than 10, we believe that we can let the patient go to the medical ward. Between 10 and 15, of course, it depends also on the clinical context. Usually, if the evolution is good, we only need optiflow or nasal high flow, and we alternate this nasal high flow with conventional oxygen therapy. And when the loss is around 20, greater than 18, so we have very, very severe patients usually, and we always need nasal high flow alternating with non-invasive ventilation with high PEEP, of course, with the classical treatment. That's all.
Thank you very much, Belaid. Very, very, very interesting presentation. So now I think we can start the question session. So I think that I have one question for you, Belaid. So did you find any correlation between the lung ultrasound score and non-invasive ventilation failure?
We're working on it with Rosanna and Sylvia, but we have no result for the moment. But what I can tell you is that when the lung ultrasound is under 10, it means that there's a lot of preserved areas, and you can be confident for the patient. It's only what I can say for the moment.
Thank you. So if we have questions from the audience, I think we can use the chat message. I don't know, Rachele.
Yeah, there is a question from Sabina, and she would be curious to know what kind of devices are used by the participants.
Yes. Yes, in the case of SAMUR in Madrid, as you can see in the presentation, we use one device of sonocyte adapted to the emergency. It's a Ruggeri-sided device, no? But we have other device of high quality for the person in charge. No, they are the SG2. They are similar to the Brussels speaker. No, and of course the device, the Ruggeri size device are not the same quality than the another device. No, for this reason, perhaps we use in two steps the echography in our service. No, for the more simple examination, like the trauma fast, expanded echo fast, or even echocardiography is enough with the usual device. No, but it is necessary another more qualified echography. We use this device of high quality.
So still talking about devices, have you any experience with wireless device? It can be useful in ambulance, on the scene, and so wireless probes can have some advantages in disinfection, or it can be wrapped into a sterile cover, so it can be protected well than other device with the cable. So we need to disinfect the cable when we use a normal standard device.
Usually we disinfect it, we sterilize it, this device the same way of the other device of the ambulance. No, every time that everywhere that we assist one COVID patient, all ambulance is sterilized by a common protocol. No, and with all device into ambulance. No, and it's not dangerous for the device. No, this is the recommendation of the company. Is not problematic for this kind of device. I don't know for another device, but for this device that we use is not problematic. The sterilization usual that we perform for the monitor, for example, or the blood test, or another electromedicine device.
So Michiel, we would like to hear about this also from you, or from your experience. Have you used a wireless device, can you hear me?
Yeah. So we use the machines from Sonocyte. So we have one big machine from Sonocyte, is the Sonocyte Export, which can hold 3 probes in one time, so you can select the right probe for your examination. We use the Sonocyte Edge for the COVID unit now, with a convex probe, and we have the iVis, is a small handheld echo ultrasound machine in the pre-hospital setting with one probe which can do linear, convex, and cardiac imaging. We don't have any wireless devices at the moment. Some of my colleagues have the butterfly ultrasound, which is very good to use, but we don't have any wireless. So the problem is the wire is difficult to clean. I think if you have a wireless probe, you can put it in a pocket, and it's more sterile, or it's more easy to for infection control.
Thank you. I have one more question for you. So when you adopted and implemented that protocol, integrating a lung ultrasound in the evaluation of COVID-19 patients, did you find any correlation with a decrease of the CT scan use? So can we do less CT scan in these patients using systematically using a lung ultrasound in the evaluation? So because CT scan may be a limited option, especially in resource limited setting, or when the patient is severely hypoxemic or hemodynamically unstable. So what was the impact of your protocol at your institution in this on the management of these patients?
So for the moderate to severe cases, we did less CT scans. We had some problems with the CT scan slots to get the patient to the CT scan. So if we had an ultrasound which showed severe signs of COVID-19 with a patient which was very bad, we send him immediately to the emergency care unit without doing a CT scan. So there was, I think, an effect on doing less CT scans for the severe patients, but they did a CT scan the day after from the intensive care unit. So I don't know if we did less CT scans, but we did less CT scans from the emergency department. What we see in the second and third wave is that we are doing more CT scans with the mild cases to rule out pulmonary embolism. So we do ultrasound for COVID-19, but the pulmonary specialists ask to do a CT scan to rule out pulmonary lung embolism. So I don't think we do less CT scans affected by the use of ultrasound, if that's the answer you need.
Clear. So regarding pulmonary embolism, I would like to hear from Cristina if they found some correlation between the lung ultrasound score and the evidence of pulmonary embolism at the contrast enhanced CT scan.
Thank you for your question. Okay, so actually, it's very related to the previous question you addressed. When I see a patient, and usually we perform lung ultrasound, and if we have a diffuse lung involvement, and we see a lot of consolidations and white lung in different areas, so a diffuse interstitial lung syndrome, and when we ventilate or add oxygen and the patient is really picking up with the oxygen levels, usually we don't look for PE, because it's very unlikely that a patient has a very good response to oxygen, has lots of consolidations, and we explain the picture of the patient based on the clinical ultrasound findings and the response to the CPAP or whatever. Obviously, if we have a patient which remains highly hypoxic or very tachycardic, we usually suspect that, and the lung ultrasound is not that bad, so maybe he has a little bit of interstitial lung syndrome, but actually we don't expect this degree of hypoxemia on the basis of a positive lung ultrasound. We basically always have a look at the heart. We try to see if we can perform compression on the deep vein on the legs, even though most of these patients, they don't really have deep vein thrombosis. They have just pulmonary thrombi, actually, so with no leg involvement. But still, we have a probe. It doesn't take that long to just have a compression on the femoral and popliteal veins. And if we are not happy with our findings, so we see a mildly dilated or dysfunctioning right heart, or pre-hospital regurg, we go for CTPA. And the thing is, I believe that the importance of lung ultrasound is that if ultrasound looks too good to explain the hypoxia, then we need a CT scan.
Clear. This is the main message. Yes, I think. So I have one more question for Ervigio. So Ervigio, if we have heard that when the lung ultrasound is low, the patients can be sent to a normal ward, and it doesn't need intermediate care unit or intensive care unit. So on the scene, can you, on the base of a lung ultrasound, can you decide to leave a patient at home and not bring him to the hospital to not overcrowd the hospital? What do you think about?
Yes. Yes, we believe that the lung ultrasound is another excellent support for the triage in the COVID. No, I live another situation like that. No, and of course the initiation of one technique always has a important curve of training, a curve of learning. No, but for us in this moment, the lung ultrasound with addition the antigen test, with addition the blood test, of course the clinic examination is one excellent support to decide if the patient go to an intensive care, go to at home even, no, or go at a normal unit, an intermediate unit. We could apply this examination, this technique, especially in the IFEMA hospital. Imagine this hospital in only 3 days, we admit in this hospital 500 patients in the first 3 days. No, it was necessary to do a special triage, no, to divide the patient in the patient of the severe COVID, the critical COVID, and the moderate COVID, because it's necessary to place the patient in different areas of the hospital. In this case, the triage with the ultrasound was especially useful, no, because it was possible in our first phase to divide it in reason of the blue protocol, the patient in a first triage, no, in this third part of patient, no, we learned in this moment that the ultrasound reach another application similar to the trauma, to the thromboembolism pulmonary, to the cardiac arrest that we performed in the last year. No, of course, we are in the first month, no, 7-8 months. Our curve of learning is not the same that the curve of learning of the people that work in the hospital, because the applicability is different. The frequency of use is not the same, and the possibilities of training is not the same. But we are sure that the lung ultrasound arrived to the pre-hospital side for always in this moment.
Thank you.
I don't know if the answer is that you wait. The answer is right for you?
Yes.
Okay.
Thank you. One more question for Belaid. Belaid, can you hear me? What are the changes of lung ultrasound in the recovery phase after the ARDS in COVID-19 patients? There is something different from ARDS due to non-COVID-19 patients? And if yes, which are these differences?
Yes, can you hear me?
Yes.
Yes, this is a completely different disease. And we were surprised by the fact patients left the unit with severe lesions. They leave the unit with multiple belines everywhere. And we were also surprised by the patients who developed after 3 weeks of mechanical ventilations severe fibrosis. And for us, it seems that patients with a lung ultrasound score remaining elevated is a good prognostic. It means that the patients still have ground glass opacities, and they leave the unit with ground glass opacities. And patients who have a decrease in the lung ultra score, and this decrease in lung ultra score sometimes means appearance of fibrosis with subpleural fibrosis, and it's a false. With this fibrosis, we have separated belines, and this appearance of separated belines is interpreted as amelioration, but indeed, actually, it is fibrosis. Of course, in some patients, you have a decrease of lung ultrasound, and this decrease is lung ultrasound is a true amelioration. So really, we are very, very surprised. And to complete the answer about the CT scan, we do not perform CT scan at the beginning now. The patients are all the same with belines everywhere, few consolidation. But after 10 days, 2 weeks, we like to perform a CT scan when we have a decrease of a PF ratio or absence of amelioration, and when we have a decrease of a lung ultra score to check that there is no fibrosis, even if we can do nothing about this fibrosis, but we like to know if we have fibrosis or not.
Clear. Thank you. There is some questions to the audience, from the audience.
So, Dr. Biasucci, are you okay with the questions? Would you like to say something more? Okay, I think that is not.
So,
Yeah, sorry.
There are no questions. So we can leave some take-home messages. So first of all, lung ultrasound is of paramount importance during a pandemic, especially when we have a massive surge of patients. And we have learned that COVID-19 patients has some specific signs, and also the recovery phase is completely different. So we have some sonographic signs which are similar to different interstitial disease, I think. But there are also some specific signs which we can take into account. The most important point is the lung ultrasound score, and it allows to assess a severity of the disease, and then we can allocate patients and then have the optimal flow management. So if we are working on emergency medical system and we go to see a patient at home, and this patient has a good saturation at the low level, but the lung ultrasound is low, if we have overcrowding hospital, we can leave the patients at home, and we can check it at distance. On the other side, when these patients come at the emergency department, we can decide using a protocol when allocate the patients, if that patients need a normal ward or an intermediate care unit or an intensive care unit, and that we can decide and monitor the disease progression. So we can assess the severity, allocate the patients, allocate the proper resource, and then monitor the disease progression and decide what kind of respiratory assistance the patients need, and so on. So and it is very important to make diagnosis, but making a diagnosis in this setting means integrating lung ultrasound with swab samples, epidemiological links sometimes, or clinical condition. So it's a very, very important tool used in different settings, and that this tool reaches a maximum effectiveness, especially in this period in case of pandemic. So this is the main message. The second message is we need protocols. So we need a protocol which integrates lung ultrasound in the evaluation of COVID-19 patients in case of massive surge of patients. And we need also a rapid training protocol in order to train all colleagues working in the emergency medical services, in the emergency department, normal ward or intensive care unit, to use lung ultrasound to assess severity and to monitor disease progression. So I don't know if the speakers each of the speakers wants to make some comment about these take-home messages, and then we can conclude. Please. Ervigio, Belaid, Cristina, Michiel, anything to add to this final comment?
I think you have said everything. I think it's important to have a good protocol, which can be a guide for ultrasound during the COVID pandemic, to have the right steps for the patients when you see something on the ultrasound. I think it's most important. If you have a good protocol, I think you can perform good ultrasound and have the right management at the emergency department.
Yeah, I agree. And probably one thing that we would like to look deeper into will be the prognostication with with lung ultrasound. So we know that we probably are dealing with two different types of patients. So if they come into very early during the disease, they have better compliance in their lungs. So probably will be very useful to start ventilation early on based on an ultrasound which is positive, which shows a lot of interstitial lung syndrome, but still with very few consolidations. So the thing is probably we need to use the ultrasound also to see which patient is still compensating on the clinical and ABG analysis, so good or fairly good oxygenation, but a not so good lung ultrasound, and maybe they are the better responders.
I agree, absolutely.
Only one affirmation. No? It's necessary to support the implementation of the ecography in the lung diseases. No, of course we can do mistakes. We can there is interference, like Cristina Sorlini has shown in the impressive presentation, but do you remember the number of false negative and or false positive of the exam of ECG, for example? No, it's normal. No, it's normal that the lung ultrasound has interference of false positive or false negative, but it's a simple, very. It's not an expensive examination. It's not necessary many consumables. No. For example, of course, it's possible the facilities, the logistics facilities of this technique that is very, very useful, and the applicability is enormous. No, I think it's necessary to support the application of this technique, but not only in the emergency department of the hospital, no, but also like us in the pre-hospital setting, no, because the difference is impressive. No, I remember the difference that suppose the implementation of the sound in the ultrasound in the trauma in our environment. No, and after that in the cardiac arrest and in the thromboembolism pulmonar, but it's the same or more with the lung disease. It's true. It's not. They don't have a great specificity, you know, but they have a great sensitivity, you know. For that, it's necessary to defend this discourse, no?
Yeah, and probably now it's much better to have false positives. So you treat the patient as if he has COVID-19. You cohort the patient, you separate the patient from the others. Maybe you ask for a CT scan, even if the swab turns out to be negative, and see, okay, this CT scan is very positive. Probably I need a bronchoalveolar lavage, and maybe we have a false positive. The false positive percentage in the nasopharyngeal swab is not low, is up to 20-30% sometimes, and we had patients with 2 or 3 swabs which were negative, positive ultrasound, then positive CT, and then on a deeper, so on the bronchoalveolar lavage, there was a positivity for COVID-19. So we don't really want to miss these patients and admit them to a COVID-free ward just because the swab says it's negative.
Yeah, great point. So if there are no further comment nor questions, I think we can conclude. What do you think, Rachele?
Yes, I think it's time. I would like to add some more things, but please, first of all, conclude.
So there is one more video because there is one more speakers and who registered a video, and it will be available on the website together with the registration of this webinar. Is it right, Rachele?
Yes, it is from Dr. Diego Mariani, also from Northern Italy.
Hello everybody, my name is Diego Mariani. I'm an emergency surgeon in Milan. I'm using ultrasound since '98, in other words, since the last century. First of all, I want to say thanks to the organizing committee for this kindly invitation and say that I'm really glad to be here. My topic today is about the lung ultrasound point of care and how this point of care application of ultrasound can help physicians in this pandemic. This graphic. All we sadly know this graphic, and we perfectly know what it means. The dreaded second wave is arrived, and it all countries harder than expected. We are facing every day an increasing number of people in our emergency department, and this overload is bringing health system under big stress. The resources are often not enough or not promptly available, or simply are not fast enough. Our emergency department are actually overcrowded from people with different needs, pushed by simple fear of COVID or for other and more serious symptoms as a fever or dyspnea. But the result is the same as you can see in the picture. The diagnosis of COVID is based on these 4 steps: symptoms, lab and blood gas test, radiology, and RT-PCR swab test. Symptoms are quite unreliable or unspecific, as you can read in this table, with exception for loss of taste and or smell. Other symptoms are unfortunately common to simply flu or gastrointestinal infection. Moreover, all these signs are not always present. About lab tests, once again we cannot find a definitive solution. The only finding reliable is the lymphocytopenia and the monocytosis, but they are not specific. About the dimer level, there is no accordance, but usually this value is high or higher than normal. All the other values are not constantly present. Worth remember that the time required to have a complete blood test panel is around at least 45 minutes. And here we are. Radiology for sure can help for diagnosis of COVID-19. CT scan in suspected cases, in other words, in those persons suspected for their clinical history or symptoms, is a really good tool, reaching a sensibility close to 100%. Not so good in the remaining people, where this value dropped dramatically around 50%. Chest X-ray, regardless the history or symptoms, have statistically a lower performance, around 60%. Unfortunately, radiology, despite represent the pivot of diagnostic process, is not priceless. It's time-consuming, it uses radiation, and it needs a cleaning process, both of machines and rooms. Finally, there is a nasopharyngeal swab. This tool is quite reliable with a good sensitivity, in average more than 90%, and close to 100% if you consider the nasopharyngeal way. The time to elaborate the results ranging from 6 hours to 45 minutes. These times are based on type of test kit, and last but not least, it depends from local organization. The availability of swab is not always enough, as we all remember in the last March and April, at least in the north of Italy. During the first wave, the swab are not available for all facilities, and any time making the diagnosis process longer than expected. And now let me introduce our guest star, the point-of-care lung ultrasound. The question are, how can POCUS help in this situation? Which type of probe is better used? It's really a reliable tool. These are the most frequent questions that comes to mind easily when you talk about lung ultrasound, and I will try to answer in the next 10 minutes. We can use both probes. Convex or linear can help. The choice is in according to the patient's body size. Remember that convex is fit for depth, but pay is price in definition. The linear probe instead have a better definition but have a low penetration power. Soldati suggests to use a single focal point modality. Avoid multifocusing. Setting the focal point on the pleural line. This approach has a benefit of optimizing the beam shape for sensing the lung surface. At the focus, the beam has the smallest width and therefore set the best response to the smallest details. Other tricks suggested are to avoid the use of cosmetic filters. Achieve the highest frame rate possible. From Soldati and Buonsenso arrived the suggestion to save your data. Visual findings, especially when related to very small alteration, do not appear on every frame. It thus advantages to acquire videos, where the lung surface below the landmark can be monitored for a few seconds during the breathing. In the setting of COVID-19, the best option is to have possibility to clean your materials in the best and sure way possible, in order to avoid the spreading of contamination. So the mantra is, wrap everything. For this purpose, wireless transducer and tablets could represent the most appropriate ultrasound equipment. This device can easily wrap in a single-use plastic covers, reducing the risk of contamination and making the sterilization procedures easy. In case of unavailability of these devices, as in the vast majority of the facility, portable machine dedicated to an exclusive use for patients with COVID-19 can be used, although maximum care for sterilization is necessary. If someone says that see the lung is not possible with ultrasound, could be some reason. Actually, with ultrasound we can see directly few things, as a consolidation or a fusion, In other words, when air goes out. But for the vast majority of cases, the art of lung ultrasound consists in interpretation of artifacts due to air bubbles, fluid entrapments, thickness of pleural line or septa, and movement of pleural line itself. The presence or the absence of this artifact are related with different clinical conditions, from pneumothorax to lung edema. Lines. Lines are an artifact due to a reverberation of sonic beam between the probe and the pleural line. Avoiding boring physics explanation, these lines are curvilinear, as the probe, at the same distance, with attenuation in according to depth. Normally are present in the normal reacted parenchyma. Considering that these lines are typical in healthy lung, is a common finding, see the pleural line uninterrupted. B-lines are created from fluid in the parenchyma. They could be normal if are less than 3 for each scan, but more than 3 are suspected for interstitial syndrome. They appear as a bright comet tail from the pleural line to the bottom of the screen. They are coordinated with respiratory movements. More than 3 per fields create a white cone. In this case, these lines are called coalitions. About interstitial syndrome, typical in COVID-19 disease, ultrasound are really helpful, having both good sensitivity and specificity. Ultrasound can and must be used to monitor the evolution of this syndrome and can anticipate the need of intubation before the respiratory impairment, even before blood cast sample and clinics appears. In this picture is well showed the evolution of interstitial syndrome in a patient. It is important to remember that these sonographic findings appear before the clinical or laboratory alterations. At this point, I should explain how to use ultrasound in a clinical setting, about what keep your mind focused, where place the probe, and after all this work, how to read the results. Daniele Bonsenso from Gemelli University in Rome have wrote a useful list of common sonographic findings for COVID-19 affected. As we can read, it's common to see the abnormality of pleura as interruption or indentation of the line, or some subpleural consolidation. Usually we can see a mix of healthy parenchyma and sick lung until a consolidation of a part of lung and air entrapment in the bronchi. This phenomenon is called air bronchogram. In my hospital, we have adopted a protocol proposed from Soldati and colleagues. 14 areas should be scanned for patient, in average 10 seconds each side, along these lines: paravertebral, mid-axillary, internipples, and mid-clavicular. In critical care setting, and for those patients not able to maintain the sitting position, the posterior areas might be difficult to evaluate. In these cases, the operator should try to have a partial view of the posterior basal areas and, however, start the echographic assessment from the lateral view. And now we're talking about the scoring system. In accordance with Soldati's protocol, there is 4 different scores, from score 0 that represent normal condition to score 3 that indicate a large lung consolidation, passing through point 1 with indented or broken pleural line and more than 3 B lines for each scan, to score 2 where the B lines are coalition under the pleural breaking point. In this picture is how they look from normal to pathological condition. All images are obtained both with linear and convex probe. In the first image, in the upper left corner, the pleural line is uninterrupted. Below, horizontal artifact may be visible. This pattern is classified as score 0. In the second image, in the right upper corner, the pleural line is not continuous. Below the point of discontinuity or indentation, vertical areas of white are visible. This pattern are classified as a score 1. In the third image, in the left lower corner, the pleural line is severely broken. Below the point of discontinuity, indicated by orange arrows, small consolidated areas appear with associated areas of white in correspondence with the consolidation. This pattern is classified as score 2. In the left corner, in the right lower side, the pleural line is severely broken. Below the point of discontinuity, large consolidation areas appear with a generalized white lung pattern. This pattern is classified as score 3. In particular, in this last image, in the box named D, ultrasound show where the age between a score 0 and a score 3 pattern is clearly visible. At the end of the scan, the operator has to report the score for each area and report the highest score for each one. The mean of the sum is the final result. This score is related with severity of patient condition, as shown in the graph on the right side of the slide. The endpoint of this scoring system is well explained from Bonadie and Bonsenso in these self-evident pictures. High score are strongly related with need of ICU admission, invasive ventilation, and finally outcome. In conclusion, I hope that my short talk could be interesting and source of curiosity for those who are searching for a dynamic diagnostic tool. Lung ultrasound showed to be one of the best instruments to help diagnosis and monitoring of the patient just point of care. And this is a great value, especially in this historical moment, where the number of people in the emergency department is so high, where the time for the right triage is so short, when it's so difficult to move positive patient and dangerous, and the clinical evolution is so fast. So, starting from the message about lung ultrasound self-evident, in particular, lung ultrasound is a bedside without danger of radiation as all ultrasound and repeatable and well fit for ICU and the critical setting. Arriving for some more consistent message, lung ultrasound for sure helped in diagnostic process and particularly during the triage in overcrowded situation. Lung ultrasound can identify properly and promptly the severity of case despite the appearance and even before blood gas test. It can be a precious aid in monitoring, identifying in advance the clinical worsening, anticipating laboratoristic and radiological confirmation. In ICU can help intensivists guiding the needs of intubation or during the weaning process. But it's important to have clear in our mind what can't do lung ultrasound, at least alone. It can do diagnosis alone and itself. Ultrasound can replace CT scan, so it's important to know why I'm asking for CT scan and what I'm searching for. I can pretend to skip laboratory test or nasopharyngeal swab with ultrasound. In conclusion, if we know the boundaries, lung ultrasound is a great tool to aid the physician in all clinical management. And this is very important in this particular moment, in this actual epidemic condition, where emergency department is so stressed. The time is really limited and mobilization of patient is difficult and moreover dangerous. Thanks for your attention. Stay safe.
I would like to thank you all. First of all, Dr. Daniele Biasucci, that chaired the session exceptionally well, really. Thanks a lot. Then Ervigio, Cristina, Michiel, and Belaid for their very, very interesting presentation and the very interesting discussion further. And I hope you enjoyed all this webinar. I hope you will decide to join us. This is our contacts. You will find the recording of this webinar, as Dr. Biasucci said, in our website in a few days. And I would like to also thank Matthew Boyds for the really, really important job he did behind the scene for organizing technically this webinar. So thank you very much, and enjoy the rest of the afternoon.
Bye. Bye.
Thank you. Bye.
Bye, and thank you.